Good morning. My topic is donor optimization and circulatory death because somebody must have been covered the organ donation. And I really pity you guys for 5 days you are going to listen the topics and after antibiotic organ donation I don't know how it is connected but it's okay. We have to adjust a lot of logistic about the faculties. See, I am going to share the information with you. I am not going to teach you anything about the organ optimization as well as the circulatory death. If you go through, there must be the whether you have covered that organ declaration of the brain death. I don't know, but assuming that if you see there is a wide gap, that means the demand versus supply. At present, there is a huge demand for the organs like liver, kidneys, heart, cornea, intestine. Every organ is needed, including the skin. If somebody has a 90% burns, from where he will get the skin? Only it is possible from the cadaver. Against that, available organs. And what we can do maximum as a part of our role as a medical doctor, how we can help those poor recipients to get the organ. That is what my whole talk. So after the death, whichever the changes happens in the brain and the human body are complex. It's like a multi-organ failure. For example, if suppose at 11 o'clock your patient is acutely brain injured, at 11:10 he becomes brain dead. Within 5-10 minutes, there are so many physiological changes happens in that patient who become brain dead. And you can, if you are geared up for that particular scenario, then you can pick up those things from the monitors, from the clinical examination, from your observation, and say that okay, this patient is brain dead, and you should not waste time in doing the further stabilization. Second thing, I always insist, our aim should not be increasing in the number of cadavers. As such, we can't do anything for the cadavers. It's like a God gift. We don't know whether this year we'll get the 5 cadavers or this year we'll get the 10. There is nobody has any control over that. What is my concern? Even if I get the 1 cadaver, maximum what I can do with that cadaver? How many organs I can retrieve? Like from 1 cadaver you can get the 8 organs: heart, lungs, kidney, liver, intestine, pancreas. Even you can get the bones. Even you can get the hand. Even you can get the skin. Even you can get the eyes. So many things. So, your role as an intensivist is to maintain that donor with the quality so that every organ will be quality. See, the maintaining donor or optimizing a donor and optimizing in the right fashion results in the number of organs retrieved. Because at the end of your exercise after 24 hours, when the team reach to your hospital for the retrieval, and if they find organs are not in a quality, you are wasting one organ. So it is not the only concept of the organ donation. How your team is geared up to maintain that donor is equally important. Second thing, it is an intensive and time consuming process. What do you mean by that? This needs 12 to 24 hours. When there are so many physiological changes happen in the body, then you have to react to that. You have to react with your therapy, and you have to react to the therapy, simultaneously react with the therapy, and you have to see the response. What you are doing and what is happening with that particular donor is going to decide your organ quality, and it needs some time and it's a costly therapy. So, how we can help? We can help by knowing the concept of the organ optimization and implementing it. So if you see this slide is very interesting. This is the last 5 years data in India. If you see 2012 to 18, these are the number of donors available. Okay, green. Kidneys, they are sustaining their number. Liver, it is picking up in last 5 years. Where is the problem? Heart and lungs. Why they are not happening? The concept of organ donor optimization. Kidney doesn't require much optimization. Liver may be okay with the marginal donor, but for heart and lungs, your donor has to be maintained with that quality. Otherwise, you are not able to retrieve that. And here the challenge is here. If the donors are available in adequate number, why we are not improving this number of the organ retrievals? And that is the role of intensivists. These are the few clips from my WhatsApp images when I am managing the patient. See what is happening in one, they say possibly hypoxia-related injury. I am losing the organ. There is a lactate is 3.6. Probably there is a hypothermia and infection. I may lose the organ. There is an active infection suspected in donor. I will lose the organ. So this type of the communications gives you the idea what type of the quality of donor you are maintaining, because it is directly affecting on your retrieval. How we can help? If you understand the whole process, there is a potential donor, that means there is a severe head injury patient, we know that he is going to become brain dead over a time, so it is a potential donor. So at that time your system should get geared up, rather than waiting he will become brain dead, he had a hypotension, he had a bradycardia, and then you will start supporting this thing. So concept of the potential donor, then explain to the family, get the consent, do the first apnea, do the second apnea, and then go for the retrieval. So throughout this chain of the events, only common system is ICU. Only common people are the intensivists. If they are geared with the concept from this potential till retrieval, you can go ahead with the management of that donor in a proper fashion. So the first part of the organ donor optimization is apnea test. You can't say that this is a part of the declaration of brain dead. Yes, it is a part of the declaration of brain dead. But during apnea, if there are what are the events of the hypoxia, hypotension, arrhythmias, and instability of the organs happen, is going to lose your organs. So one should know how to do apnea in the right fashion. One should know when to do apnea. One should know what are the different precautions you have to take it during the apnea. One should know in difficult situation how to do apnea. At present there is no alternative for apnea in declaration of the death. So first thing is a pre-oxygenation before this thing. Whatever the saturation, just give effort to 100% and maintain 100% saturation before you disconnect the ventilator. Do the ABG. Then disconnect the patient for ventilator for 10 minutes. Then take the ABG after 10 minutes. And then ABG repeats after 10 minutes. If there is a CO2 rise of the 20 from the baseline, it is very important. If suppose your CO2 is 25 to start with, at the end of the 10 minutes it has to be the 45. But if your CO2 is 55 to start with, it has to be 65. So you cannot take the absolute value of the 60. It has to be the 20 from baseline. Why 20 for baseline? Because you are disconnecting the ventilator for 10 minutes. Why 10 minutes? Because every minute there is a rise of the CO2 by 2. This is what the calculation behind this. So if you see, there is a disconnection of the ventilator. Ventilator is completely disconnected. You are monitoring hypoxia, hypotension, arrhythmias, because even single event of the hypoxia is going to affect on your organ quality. I am doing the first ABG before disconnecting. After 10 minutes I will do this thing. Now the simple things, like for example the diameter of the ETT and diameter of the catheter of the oxygen you are putting inside, it has to be the less than 0.6. Why is this so important? If you keep this diameter larger, then there will be air trapping, and this may landed with the pneumothorax. Sometimes you may landed with the pneumothorax during the apnea. The simple reason is that might be your catheter size and the diameter is not adequate. It has to be the less than 0.6. Second thing, the flow. Whichever the oxygen flow meter you are taking, it has to be the 4 liter. Why you want 15 liter? If you give the too much flow, then again there will be the air trapping and landed with the pneumothorax. So there are two things which matters during the apnea. Is your size of the catheter you are putting inside the ETT, it has to be the less than 0.6 of the diameter. And second thing, the flow of your oxygen, it has to be the 2 to 4 liter. Your saturation has to be 96 to 98. So this is how ideally one should do apnea test. This matters because my organs are at stake. In difficult situations, suppose my patient has an ARDS, suppose my patient is in a neurogenic pulmonary edema, suppose my FiO2 requirement is 100 with PEEP of 10, and I don't want to lose the organ, I want to do the apnea. Yes, you can do the apnea. This was a beautiful paper in 2016 in the Internal Care Medicine Journal, where the 269 patients with the difficult to disconnect, they are with all ARDS possibly, they have done it successfully with the help of the PEEP valve. What is mean by that? There is a AMBU bag with the PEEP valve. This is easily available. It's only 5,000 cost. What you have to do in these patients, this group of the patients with the ARDS, first thing like in any other patients, you have to recruit the lung. Just do the recruitment maneuver, make the lungs expanded, maintain the PEEP, maintain the oxygenation, and then disconnect and put them on the AMBU bag with PEEP valve. So what will happen? It will not allow to de-recruit the lung. And then you can continue your apnea test. It is 100% successful in this 269 patients. The 40 patients out of 260 were on ECMO. So ECMO is also not contraindication for doing the apnea. Just get away from that phobia of the difficult apnea in severely hypoxic patient. It is easily possible. There is a third paper, unfortunately I didn't include, just 2018, there is another paper came on the apnea with the CPAP. That means if your patient, no need to disconnect, let's just put them on the CPAP. This will reduce your hypoxia event during the apnea. Second thing, it requires only 5 minutes to generate that 20 CO2. But the only problem in Indian setting or our ventilator, there is a backup ventilation. If you put the CPAP with the backup ventilation, then you can't do the apnea. You have to call your biomedical engineer, just disconnect that facility and then continue. That is it. But again, in India, our constitution doesn't allow CPAP method. At present, we have to go ahead with the either TPs or Ambubag with P. But in future, it is due. Okay, now you are after the first and the second apnea, you are able to avoid the hypoxia, hypotension, arrhythmia event. Then you are coming for the management of that donor, that is optimization of donor. What are the key principles? Key principles like general ICU care. All ICU cares for the organ support. We'll go one by one. Then the problem or issue is the number of organs. Your aim of the management of the cadaver organ should be maximum outcome. If I am given a choice, I will get everything possible. In one patient, we had a heart, we had a lungs, we had a kidney, we had a liver, and both hands. Both hands we were given to the AFMC because one soldier was needed for that, and we transplanted those hands. So you can do wonder. If your team is geared up, you have clear concept, then you can do the maximum things. Then frequent clinical assessment. These donors requires frequent. See, what I do, if suppose I have a cadaver donor in my ICU, I allocate one senior resident doctor or consultant for that bed, because that particular patient, that patient is going to save 8 lives. So my one doctor is for 8 patients, not for one patient. So I don't argue with anyone. I say just one person dedicated till that patient reaches to the OT. So that person is aware about he has to deal with so many teams. He has to deal with the liver team, heart team, kidney team, every team, and they have their requisite. I want a coronary angio, I want echo, I want procalcitonin, I want this thing. So he has to manage patients with the team. And there is no way you can refuse your job, because one donor is equivalent to the 8 lives. So it is a clinical assessment and the response. And the time. It has to be as short as possible, because these patients are on high supports, there are a lot of metabolic changes are happening, physiological changes are happening. You may land with losing donor also. If you see the common, what is happen, when once the patient become brain dead, these are the commonest events, like 80% time they will land with the hypotension, 85% time they will land with the diabetic insipidus, 30% time they will land with the DIC, cardiac arrhythmia will be 30%, pulmonary edema will be 20%, and acidosis will be 10%. So one should be aware what you are going to anticipate in those patients. What is happening? What is the pathophysiology? What is pathophysiology? When the acute brain injury change into the brain dead status or brainstem status, what is happening? They are increased ICP, that is a refractory ICP, suddenly raise ICP, and that can cause the hypotension, bradycardia, tachyarrhythmia. So if you are in front of the monitor and suddenly heart rate become from 80 to 160 in a severe head injury, you may say that he is becoming brain dead. Or suddenly there is a bradycardia of 40, or suddenly BP was 150/90 with the 2 ml of the NORAD and suddenly becomes 60. So these are the certain indications is giving the idea that his ICP is raised, it is probably refractory ICF, maybe he is going to the brainstem status. And then loss of the vasomotor control. Then say there will be hypertension, and then again hypertension. Then there is a massive release of the cytokines, decreased circulatory pituitary hormones, which results in the diabetes insipidus, and relative adrenal insufficiency, hyperglycemia. Like for example, sugar is 200 and sister to that bed comes to and say, sir, sugar is 600. How can within 1 hour sugar from 200 to become 600? In a patient which is 2 days with you, and neither 5% dextrose is given, nobody pushed the 25% dextrose, nothing happened to that patient. That is the indication you may have an idea that this patient is likely to be brain dead. So arrhythmia, one of the most common thing happens in a brain dead state is hypocalcemia, hypomagnesemia, and hypohospital. Correct those things. Most of times there will not be arrhythmia. Other arrhythmias, there is tachyarrhythmias. If it happens, the drug of choice is Cardiolon or Amiodarone or cardioversion, no other drug. If bradyarrhythmias happen, please do not go for the atropine, because there is a loss of a vagal reflex. So the treatment is either isoprenaline or pacing. So you should know what you are doing for the brady and tachyarrhythmias. Central diabetes insipidus, these are the clues for the central diabetes insipidus. Drug of choice will be vasopressin and desmopressin. Even nasal desmopressin sprays are available. No need to memorize the doses. Fluid management. One of the key aspects of the management of optimizing donor is the fluid management. Generally, either there is a hyponatremia or hypernatremia. If your sodium is less than 150, your choice of the drug will be balanced solution, 100 to 200 ml per hour. If your sodium is jumping more than 150 because of the severe neuronal damage, then your drug of IV fluid choice will be 5% dextrose plus half normal saline. You can just have some fixed formula. If your sodium is 150 to 155, you can give 500 ml over 2 hours. It is 160 to 165, 1500, and if it is more than 170, you can give even 2 liter in a 2 hour. See, don't hesitate to bring down that sodium because patient is already brain dead. You don't bother about anything happens to the brain center, pulmonary malaise, nothing. You just rapidly correct that sodium because in presence of the hypernatremia, you cannot do the apnea. It is not reliable. It will be relative contraindication because in severe metabolic status, you cannot do any apnea. So you have to bring down that sodium rapidly, and you may use such IV formulas to bring it down. So what are your targets in hemodynamic management? Your mean arterial blood pressure should at least minimum 60. Your urine output should be 1 ml per kg per hour. Your ejection fraction at least 45, and he has to be on the lowermost vasopressor dose. Throughout management, try to maintain euvolemia. In advanced hemodynamic, in spite of the adequate hemodynamic fluid management, if the patient requires, please go ahead with the mixed venous oxygen saturation management. Lactates, follow the lactates. Like in first slide I show lactate is 3.6. That gives you the idea patient may need the fluid, base deficit and acid base status. So in cadaver organ donor, we advise ABG with electrolyte with lactate every 3 hourly, sugar every 2 hourly. So we are continuously monitoring the changes in that patient. Echocardiography. Please do not do the echocardiography for the assessment of the heart when the patient is in hypotension or on high support. That is not reliable. You have to wait till patient becomes hemodynamically stable and on the minimal support. Otherwise, your echo may misguide you regarding the heart status. Then inotropes, drug of choice is vasopressin is the first drug of choice. Noradrenaline, you can make the combination or you can use it as per your experience, but drug of choice is vasopressin as a first line. Dopamine, dobutamine, epinephrine may be used in a cardiac pump dispensation, may be used as per the situation. The most important thing, in spite of your all adequate fluid as well as the inotropic management, if you are unable to achieve your hemodynamic goal, that means he requires hormonal therapy. So your hormone therapy will come into the picture after adequate resuscitation, and actually hormonal therapy to maintain your hemodynamic status, it will help. Then mechanical ventilation, it is a lung protective strategy. Keep them on the very basics with the normal apnea. So tight volume 6 to 8 ml, PEEP, plateau, normal apnea, normal pH, and as per your lung status, decide about the lung recruitment and rest of them. So you have to continue aggressive ventilatory management as in other patients. In fact, you have to give more and more importance to the management of these patients because they are going to save your next 8 recipients. Then hormonal therapy. What is the role of hormonal therapy? It improves the hemodynamic. Already I explained. It reduces the vasopressor requirement. Increase the number of expanded criteria donor. Might be if you get the achieve hemodynamic status in a time in a better position, you can achieve the more and more organ retrieval and improve post-transplant organ function also. So hormonal therapy is one of the key aspects of management of cadaver organ donor. And this was one of the paper which was showing the results with the hormone therapy and without hormone therapy. If you see the hearts, there is an increased number 34 versus 25. If you see the kidneys, it is 70 versus 64. Except the liver, there was no much difference in after the hormonal therapy. And this is with the retrievals with the hormonal therapy. So hormonal therapy definitely has a role in stabilizing the hemodynamic as well as giving results post-transplant also. So which cocktail you will use? Generally it is known as a cocktail of the hormones in cadaver organ. You will use the steroids, then you use the thyroid hormone and vasopressin. Generally this cocktail is very common in managing your cadaver organ donor. Vasopressin as a drug of vasopressor, then your steroids and your thyroxine. Your steroid dose is 15 mg per kg and thyroid hormones as per the situation. But definitely it helps in stabilizing your donor. Infection, it's a big issue. Infection is one of the major issue nowadays we are facing in our organ donation, because it doesn't matter your patient is with you 24 hours or 48 hours. Sometimes they may are carriers for the certain infection. So whether it is a contraindication, no. Infection transmitted by donor is first thing very rare. If suppose patient has a pneumonia, that particular brain dead patient, it is localized, not necessarily it is a systemic. So if you retrieve heart and the liver and kidney, probably there is a chance of the infection is less. So infection transmission by organ donor is rare. However, it is associated with the significant morbidity and mortality. So what to do? Assessment and selections are more difficult in these cases because short time is available. Like for example, I receive a patient on the day 2 he become brain dead, I have to retrieve the organ within 24 hours maximum. So I get hardly 2 to 3 days to do the assessment in terms of infection, whether he is a colonizer, whether he is infected, whether he is a non-infected. That is the problem with this donor. Assessment of the donor include the blood culture, irrespective of the fever, irrespective of the WBC count, irrespective of the clinical status, please send blood cultures if you are considering him for any organ retrieval. Collect at least 2 samples and respiratory samples if you are considering for the lung transplant. Donation from the donor with a bacterial infection is not a contraindication. Please, even infected donor is not a contraindication for organ donation, provided donor has undergone the efficacious antibiotic therapy. Suppose I have a donor, after 5 days I declare and he probably acquired Acinetobacter. Okay, he is hemodynamically maintained, his organs are good quality as per my test. My retrieval teams have also given me the green signal for going ahead with the retrieval team. My concern is infection. What I will do, I will give them the antibiotic in adequate doses as per the culture sensitivity or as per my experience, like meropenem 2 gram 8 hourly with the cholesterol bolus followed by 3 milliliter. And I will continue those set of the antibiotic in recipient. So my communication with the recipient team or the retrieval team has to be the very good. Like this patient probably go on a gram-negative organism, most likely Acinetobacter. I have given meropenem, I have given colistin. You please follow for at least 7 days, and that is way you can go ahead with the organ donation. Donor colonization by multi-drug resistant bacteria is not a contraindication. Again, if suppose you grow MDR and resistance organisms also, that is also not a contraindication for organ, because we are so short of organ. And this is all by evidence. This is no personal comments. These are all by evidence. These are not a contraindication. Only you have to take a proper care while selecting those donors. However, organ donors from the invasive fungal infection should not be used. That is the only contraindication in terms of infection. So make a checklist like what you are do, the regular basic monitoring, what you do the routine investigation and special, like continuous monitoring has to be there, temperature, urine output, oxygen saturation, your goals, your investigations you will follow on regular basis. In certain situations you may go ahead with the further special management if the patient is hypothermic or if the patient is due for the heart transplant or there is hypernatremia or there is any other issues arising. So put a monitoring chart for these patients, checklist and follow them. So what is the take home message? Consent has to be there. Donor quality, my take home message in donor optimization is the quality of the organs and quality of the multi organs is more required and targeted rather than only doing the donation. So your concern will be the appropriate fluid management, hormonal therapy and the antibiotic coverage. And this should be your goals while managing, like heart rate, blood pressure, your urine output, your electrolyte, blood gases and ventilator management. That is where you should go for the targeting optimization of the donor. Dr. Deepak Goyal particularly requested me to cover death after circulatory, donation after circulatory death. Probably previous speaker haven't covered. So I am going to cover. See, it is equally important. What I told to start with my lecture, I said our aim is the retrieval of the maximum organs. The quality and the number of organs is our this thing. This is the same. This topic is related to same, because at present we are having that ratio is becoming day by day worse. Like even in news today, they have provided the statistics that only 7% of the listed recipients are getting the organs. And the reason is very simple. You cannot create cadavers. You can manage the cadavers, you can get the more number of the organs available for the donation, but you cannot create organs. What is the alternative solution for that? Donation after circulatory death. In Western countries, they are changing, they are completely changing from brain dead donor to the circulatory death. And their numbers, they are going up. Because this is the future. I will tell you what is the status in India. So if you see the case, this is very typical scenario. Young patient, she was working and then she had a SH, extensive bleed. She fell down, admitted to the hospital in unconscious status, GCS of 3, prognosis is poor. Now, situation is that family is ready for the organ donation, but she is not brain dead. Now, problem is that there are so many patients in our ICU are on the verge of the brain dead, but they are not brain dead. And if they spend more time in your ICU, they are going to pick up your infection, they are having the more cost, and then family become restless. The situation is that family is willing, but she is not brain dead. You cannot retrieve the organs. You have to wait till that brain dead thing happens. And there is no control over the time. In this situation, the solution is donation after circulatory death. What do you mean by that? So which are the potential DCD donors? Like those patients who are catastrophic brain injury who have not deteriorated with brain death. Suppose if in my given ICU any 20 beds, there might be the one brain dead patient in a month, but there are at least 4 to 5 patients who are on the verge of the brain death, but they are not brain dead. So these are the patients like SH patients, spinal cord injury or injured muscular. So these all are your candidates for organ donation, provided if Indian government agrees for this concept. At present, there is no such facility in India. So what is the types of the organ donors? This death after circulatory death, there are uncontrolled death and controlled death. What do you mean by uncontrolled death? Like somebody brought to the casualty in a cardiac arrest status. We don't know whether he arrested 5 minutes back or 15 minutes back or 15 minutes back. So there is no control over the death. It is uncontrolled death. When the controlled death is patient is in my ICU, I know he is going to die. I am preparing for the organ retrieval. I explain to the family is willing. I am allowing him to arrest, go to the asystole, and then I will come back I will go ahead with the organ retrieval. I will explain what is meant by that. So, in death after circulatory death, you should know what is the definition of death. The definition of death is absence of the central pulsation, absence of the heart sounds, straight line on the ECG, absence of the pulsatile flow using the direct inter. So many things you will correct. And the most important thing, you have to wait for 5 minutes. Suppose the patient is in front of me, I decided to go ahead with the death after circulatory death, consent is with me, family is with me, everybody is with me. I will withdraw the support and I will wait till straight line happen. Then I will confirm all these things at death and I will wait at least 5 minutes. And after 5 minutes, these findings are still persistent, I will declare death. Suppose in between 5 minutes, patient had a breathing or patient had a heart rate or rhythm. Then I have to go back again with the ventilator management. Again after 10 minutes, I will try that 5 minutes manual. So the must part is the 5 minutes period has to be there before declaring them dead. So this is the classification of the DCD, class 1, T3, 4. Like class category 1 is dead on arrival, uncontrolled. There is no way you can consider. Category 2, unsuccessful resuscitation. The patient brought to you, bradycardia, going into the arrest, resuscitated, again going into the arrest, uncontrolled. Category, anticipated cardiac arrest. We know that this patient is going into the arrest. We know that this is the control. It is happening in front of us. Category 4, cardiac arrest in brain dead donor. Sometimes brain dead patients are in our ICU and they are having the cardiac arrest, but it is controlled. And category 5 is the unexpected arrest in ICU patients, again uncontrolled death. So in India, the problem is our system or our constitution doesn't allow us for withdrawal and withholding. So we cannot go ahead with this system at present. But this is where in Western countries they are moving ahead with changing those potential donors into the brain dead donors. Like they are allowing to have a systole and then retrieving the organs. Now how they are going ahead? You should understand the concept of the warm ischemia and the cold ischemia. So what is the warm ischemia? There is a donor warm ischemia and the recipient warm ischemia. Donor warm ischemia means when you are having a systole in that particular patient, DCD patient, then you are retrieving that organ, still cold perfusion starts. That is a donor warm ischemia. And what is recipient warm ischemia? You are removal of the organ from ice and you are doing the reperfusion before transplanting into this thing. And the difference in between that is the cold ischemia. Why it is important? Because the organs, every organ has a different time limit. For kidney it is a 120 minutes, for liver it is a 30 minutes, for lungs it is a 60 minutes, and pancreas it is 30 minutes. Now please don't get confused with the branded donor. This is the DCD donors. That's why your warm ischemia time is much less. In branded donor, your ischemia time is 4 hours, 6 hours, 24 hours, 72 hours. Here you are allowing to become a asystole. Your blood flow is completely stopped. And then you are picking up those organisms and going to retrieval. So you have to do all these things within at least 20 minutes or 30 minutes to get these organs. And that is what this slide says, which are the optimal donor after DCD and which are the suboptimal donors. Like optimal donors means time to death is, that means they are stick in that criteria of the reperfusion. And suboptimals means they are extending time. So you can consider, because at present we are in need of the organs. So how to proceed that? What is the process of the death after circulatory death, donation after circulatory death? First thing, you have to say that, document, there is a treatment is futile. Like example, she has a SAH, there is a GCS is 3, pupils are dilated fixed, but still there is a spontaneous expression, cough and gag is there. That means it is a potential donor. But family says we are willing. I am not discussing on the Indian background. I am just giving you the concept at the Western background. At present, India, nobody does the death after donation after circulatory death because our law doesn't support it. So what you have to say, patient is a potential donor, family is willing for organ donation. So what I will do, I will first document, okay, definitely she is not futile to continue. Then I will take the consent of the family. Then management before the withdrawal. That means I will call the family members. Generally in Western countries they do it in a OT, all these exercises. You may do it in a ICU, but provided that you are after that asystole, you have to reach to the OT within 20 minutes or 15 minutes, which is likely to be very difficult. So then I will call the family, I will brief them, I will go ahead there with the rituals, I will explain them, I am going to tell them that now we are going to retrieve withdraw the life support. Then we will do the withdrawal of the life support in front of the family. We may allow the family members around the bed. That means we will disconnect the ventilator, we will disconnect the tube, we will stop the inotropes. Okay, so we are allowing control death. This is a control death. So then we will allow the control death. Then diagnosis. That means then after few minutes there will be asystole. I will wait for 5 minutes. I will confirm after 5 minutes also that there is a asystole. So now I will declare the death. If I am in OT, one OT I will go to the retrieval OT. If I am in ICU, I will shift the patient to the OT. Now your patient is going into the OT. And then organ retrieval. And the time in between the shifting to the OT and retrieval has to be the less than 120 minutes for kidney, 60 minutes for the liver, and 30 minutes for the pancreas. So your team has to be ready accordingly. After transport to the operation room, this is another scenario. Either you do it in ICU or you do it in OT. You can remove and go for the organ retrieval. So withdrawal of the life support, death. If yes, after 5 minutes I will confirm and I will go for the retrieval of the organ. This is a flow of event. What is the Indian scenario? Indian scenario is very bad. DNR and end of life care are at present in a grey area. In India, DNR, withdrawal, withholding, euthanasia, active, passive are not allowed in our at present legal system. Only what is accepted just now? Living will is accepted. But unfortunately, that process is also very tedious. That means you have to have a will, then living will, then they will. You have to have a medical board in your hospital. Then after that certification, you have to approach the High Court bench, and then they will say you may go ahead with the withdrawal. So difficult. Then we cannot go withholding and withdrawing. So how you can declare the circulatory death? Ethical issues, malpractice. How to control the malpractice in India? It will be very difficult in this area. Then understanding of the DCD this thing in our setting. NOTO. At present, NOTO has no stand on this issue. It's silence. When somebody is silent, we should be always against. No need to push for this particular concept. Do we require the new legal provision under Act? Yes. If you match to those required organs in your practice, you need to find out the ways where you can't lose these such donors. So, key points: donation after circulatory death is an accepted strategy to expand the potential donor pool. One of the major concerns is it may expand your potential donor pool. Donors have challenged the medical ethical transplant committee with the definition of the circulatory death. Still it is going on, but whichever the definition I have explained, that is acceptable. And new organ preservation method to better protect and recondition the deceased organs are being developed, including in situ normothermic recirculation before and ex situ. That means if your decision is there for the retrieval, after the consent, before withdrawal, you can just maintain those organ temperature, and after a systole, go for the immediate retrieval and maintenance of the temperature. Thank you.
Thank you, sir.